All right, so we're diving into anesthesia today.
Oh, yeah, this should be fun.
And lots of people have asked for this one, a real deep dive on anesthesia. So,
I'm excited.
yeah, we're going to get into general, regional, local.
Whole gamut.
And for this one, we're going to be using mainly your medical school study guide as our source.
Perfect, yeah.
So,
That's a good resource.
it should be. Our mission, if you will, today is to walk through basically the steps of general anesthesia so you really understand what's happening. Then we'll get into numbing specific parts of the body and then how local anesthetics work.
Love it.
All right, so let's start with the basics. When we say general anesthesia, what does that actually mean?
Well, the official definition from our source here says, general anesthesia is a drug-induced loss of consciousness during which patients are not arousable, even by painful simulation.
Okay, so it's more than just being asleep.
Right, way more. You're literally put to sleep so deeply you can't breathe on your own.
Whoa, okay, so how do they even get you to that point?
It's a pretty involved process, actually. It's not just one thing. It's a multi-step sort of recipe. And there are four main steps we're going to talk about.
Yeah.
Induction, neuromuscular blockage, maintenance, and emergence.
Okay, so induction, that's like the getting you under part, right?
Exactly. So there are a couple ways to do this. The most common is through an IV, but sometimes they use inhaled gases too, especially with kids.
Makes sense. I mean, who wants a needle if you don't have to, right? So with IV induction, what are they actually putting in there?
Well, they need to hit three main things: amnesia, analgesia, and then, of course, unconsciousness.
So amnesia, that's like making sure you don't remember anything.
Yep, basically wiping the memory slate clean. They use drugs like benzodiazepines for that: diazepam, midazolam, lorazepam. You might recognize some of those names.
I've definitely heard of a couple of those.
Yeah, pretty common. Or sometimes they'll use barbiturates.
Okay, and what about the analgesia part? That's pain relief, right?
Right, got to make sure you're not feeling anything. For that, they'll often use things like IV acetaminophen or opioids like fentanyl.
Oh, wow. Serious painkillers then.
Yeah, and actually, there's one drug that pulls double duty for both amnesia and analgesia: ketamine.
Ketamine. Isn't that used for other things too?
It is. It's actually pretty versatile. But in this context, it's great for inducing anesthesia.
Interesting. And then there's the actually knocking you out part.
Right. For that, they might use something like propofol through the IV. Or if they're going the inhalation route, there are gases like sevoflurane.
Okay, so you're out like a light at this point. What's next? Neuromuscular blockage, you said.
Now, for the part where your muscles are completely relaxed,
Uh-oh. Sounds a little scary.
don't worry, you're already unconscious at this point.
Hmm?
But it's necessary because even when you're asleep, your muscles can still be tense. And that would make it really hard for the surgeon to do their job.
Makes sense, I guess.
Yeah.
So how do they achieve this muscle relaxation?
Well, there are two main types of neuromuscular blocking agents. First, there are the depolarizing agents like succinylcholine.
Depolarizing. What does that even mean?
It basically means it overstimulates your muscles to the point where they can't contract anymore. Think of it like overloading the system. It's usually used for really short procedures.
Interesting. And how do they reverse it?
The weird thing about succinylcholine is that it doesn't really have a reversal agent. You just kind of have to wait for it to wear off. Or sometimes they'll do a fresh frozen plasma transfusion to speed things up.
A plasma transfusion? That's wild.
Yeah, it's pretty unique to this drug. Now, the other type of neuromuscular blocker is the non-depolarizing agents, like pancuronium or vecuronium.
And those work differently.
Yep, these guys actually block the signals from your nerves that tell your muscles to move. They're longer acting, so they're good for longer procedures.
Okay, so they basically paralyze the muscles temporarily. And can you reverse those?
Yeah, these ones you can. They use a drug called neostigmine to reverse the effects.
Fascinating. So you're unconscious, your muscles are relaxed. What's next on our four-step anesthesia journey? You said maintenance.
Right, maintenance is basically just keeping you asleep and pain-free throughout the surgery. They'll adjust the medications as needed, whether it's the inhaled gas or the IV drugs, to make sure you stay comfortably under.
Okay, so that part's pretty straightforward. And then eventually you got to wake up, right? That's the emergence phase.
Exactly. Waking up time, they'll gradually decrease the anesthesia and let you start breathing on your own again.
I bet that's a relief, waking up and realizing it's all over.
For most people, yeah.
Okay, but hold on a sec. We've talked about the drugs, but haven't really touched on one very important thing: breathing.
Ah, yes, good point. Because general anesthesia impairs your ability to breathe on your own, we need to make sure you're getting enough oxygen throughout the whole process.
So how do they do that? Is it just like hooking you up to an oxygen tank?
It can be a bit more involved than that. There are two main categories of airway support, non-definitive and definitive.
Okay, and what's the difference?
Non-definitive airway techniques are simpler, temporary measures. Things like tilting your head back to open the airway, using a bag mask device to manually ventilate the lungs.
So like squeezing a bag to push air into the lungs.
Exactly, yeah. It can be effective, but it has its limitations. It can be tiring for the person doing it, and there's a risk of air getting into the stomach instead of the lungs.
And what about those airways?
Those are devices that help keep the tongue from blocking the airway. They're often used in combination with a bag mask. Then there's the laryngeal mask airway, or LMA.
LMA? I think I've heard of that.
Yeah, it's basically a mask that sits over the larynx or voice box. It provides a seal around the airway, but there's still a risk of aspiration, especially if the patient vomits.
Aspiration, that's when stuff gets into your lungs, right?
Yep, definitely something we want to avoid.
So those are the non-definitive options. What about definitive airway support?
That's where we get to the gold standard, endotracheal intubation.
Ugh, the ET tube. Down the throat it goes. But seriously, why is that considered the best option?
Well, when that tube's in place, we know for sure that the airway is secure. We can deliver oxygen directly to the lungs and control ventilation much more precisely. Plus, it significantly reduces the risk of aspiration.
You know, speaking of ET tubes, did you know that the tip of the tube has to be placed very specifically to avoid complications? Like it has to be about 2 centimeters above the carina?
The carina.
Yeah, it's where the trachea splits into the two main bronchi. If the tube goes too far down, it could cause a pneumothorax.
A collapsed lung. Yeah,
Yeah.
definitely not good. So how do they make sure they've got it in the right spot? Like how can they even tell where the tip is once it's down there?
Well, they listen for breath sounds on both sides of the chest, make sure the chest is rising and falling symmetrically with each breath, and monitor the patient's oxygen levels and CO2 levels.
And sometimes they'll use a special device that detects CO2 in the exhaled breath, or even take an x-ray to confirm the placement.
So a lot of checks and balances to make sure it's right.
Absolutely, safety first.
Okay, so we've covered a lot of ground here with general anesthesia. Putting you under, making sure you're breathing. Sounds pretty complex. But are there ever, complications?
Well, like with any medical procedure, there are always potential risks. Even with the best techniques and most skilled professionals, things can sometimes go wrong.
So what kinds of things could happen during either intubation or extubation?
Well, during intubation, there's a small risk of dental damage, especially if the patient has loose teeth or dentures. There's also the possibility of esophageal intubation.
Wait, esophageal, isn't that the tube going down the wrong pipe?
Exactly. Instead of the trachea, the tube goes into the esophagus, which leads to the stomach. That's why we have all those checks in place to make sure it's in the right spot.
Makes sense. And what about during extubation, when they're taking the tube out?
There's a risk of aspiration if the patient hasn't fully regained their cough reflex. Or they could develop laryngospasm, which is where the vocal cords suddenly spasm and close up, making it difficult to breathe.
Sounds kind of scary.
It can be, but thankfully these complications are relatively rare, and anesthesiologists are trained to recognize and manage them quickly.
That's reassuring. Okay, so we've talked about the general risks, but is there anything else, any specific conditions we should be aware of?
Well, there's one rare but serious complication I want to mention. Malignant hyperthermia.
Malignant hyperthermia. I think I've heard of that. Isn't that, genetic?
Yeah, it's an inherited condition. Basically, people with this genetic predisposition can have a really dangerous reaction to certain anesthetic agents.
What kind of reaction?
It's pretty dramatic, actually. Their body temperature shoots up rapidly, their muscles become rigid, their heart rate and breathing speed up. It can even lead to organ damage if it's not treated quickly.
So what causes this reaction? And is there anything they can do about it?
The most common triggers are succinylcholine, which is one of the muscle relaxants we talked about, and halothane, an inhaled anesthetic. And the treatment is dantrolene sodium. It's a muscle relaxant that specifically targets the process that's going haywire in malignant hyperthermia.
So if they catch it early, they can usually prevent serious complications.
Exactly. That's why it's so important for anesthesiologists to be aware of this condition and to have dantrolene readily available just in case.
It's amazing to me that they can, essentially turn off pain and consciousness, but still keep you alive and functioning.
It is pretty incredible when you think about it. But it just goes to show how important anesthesia is to modern medicine.
Absolutely. So we've covered a lot of ground here with general anesthesia, from how it works to the potential risks involved. But what about when you don't need to be completely knocked out? What about those times when you just need to numb a specific part of the body?
Well, that's where regional and local anesthesia come in.
Ah,
And that's a whole other fascinating story.
I'm ready to hear it. Let's dive into those next.
So regional anesthesia, it's like we're not turning off your brain completely,
Yep.
just targeting specific nerves,
Gotcha.
blocking pain signals from a particular area of the body.
So you're awake.
Yeah, you're totally awake and aware, but you just don't feel anything in that specific region.
Okay, so it's like creating a numbness zone, sort of.
Exactly, temporary numbness zone. And there are a couple main types we can talk about.
Yeah, like what are the common ones people might have heard of?
Well, epidurals and spinals, those are the biggies.
Yeah, epidurals, that's like for childbirth and stuff, right?
Oh, absolutely. Very common for labor pain management.
So how does that even work?
Okay, so picture your spinal cord, right? It's surrounded by this membrane.
Mm-hmm.
And with an epidural, we inject the anesthetic just outside that membrane
Oh, okay.
into the epidural space. It takes a little bit longer to kick in, maybe 10 minutes or so.
So it's not instant.
No, not instant. But the cool thing is we can use a catheter.
A catheter, like a little tube.
Yep, tiny tube.
Yeah.
And we can provide continuous pain relief through that catheter. So it's great for longer procedures or even for managing pain after surgery.
So that's why they leave it in sometimes after you've had surgery or something.
Exactly. Now, spinals are a bit different.
Different how?
Well, with a spinal, we go right into the cerebrospinal fluid.
Oh, wow. So that's the fluid that's like bathing the brain and spinal cord.
That's the one. And because we're going right into that fluid, the effect is much faster.
So it's instant pain relief, basically.
Pretty much, yeah, within minutes usually.
Wow, that's amazing. So spinals are faster, epidurals last longer. Anything else that's different?
Well, spinals tend to wear off quicker, too.
Okay.
So they're great for shorter procedures. Epidurals, with that catheter, you can keep it going for much longer.
So it just depends on what you need it for.
Exactly. It all depends.
It's pretty crazy, though, when you think about it, that they can pinpoint these specific areas of your nervous system.
To block pain.
Yeah, like where does the spinal cord even end? You know?
I have no idea.
It ends around the level of L2.
L2.
That's the second lumbar vertebra. But the nerves, they keep going down from there.
Oh, okay.
It's called the cauda equina.
Cauda equina, huh? Like a horse's tail? Yeah, exactly. It looks just like it. Anyway, that's relevant for where we do these injections.
Fascinating. So much anatomy involved here.
Oh, for sure.
But I gotta ask, are there, like, any downsides to these techniques?
Well, like with any procedure, there are risks, right?
Yeah, of course.
Infection, bleeding, those are always possibilities. And with spinals, sometimes people get a headache afterwards
Oh, really?
or drop in blood pressure. But thankfully, those are usually temporary.
Okay, so it's not risk-free, but
I guess.
but pretty safe overall, it sounds like.
Yeah, for the most part.
Okay, so we've talked about, like, blocking pain in these larger regions.
Right.
But what about when you just need to numb a very small area?
That's where local anesthesia comes in. The pinpoint precision strike force.
Uh-huh. I like it.
Yeah, think of it like this. You've got a mole you need removed,
Okay.
so they just inject the numbing agent right around that mole.
So it's super targeted.
Super targeted.
Right.
Lidocaine, Novocaine, those are the classics.
I've definitely heard of those. But, like, how does that even work? How does an injection make you not feel pain?
Well, it's all about nerves and how they send signals.
Okay.
Nerves use these charged particles, ions, to transmit electrical impulses. Sodium is a big one.
So it's like electricity, basically.
Kinda, yeah. And local anesthetics, they block the channels that let sodium into the nerve cell.
So the signal can't get through?
Exactly. Pain signal blocked. Poof.
Wow, it's like they're short-circuiting the pain pathway.
That's a great way to put it.
Science is amazing.
It really is. And there are different types of local anesthetics, by the way. Some wear off really fast, others last for hours.
I guess it just depends what they're using it for.
Exactly, the right tool for the job.
So it seems like local anesthetics are pretty straightforward.
Yeah, generally pretty safe and easy to use.
But are there ever any problems, like side effects or something?
Well, everyone reacts differently to medications, right? So some people might get a little numbness or tingling that spreads beyond the injection site.
Like when you get a filling at the dentist and your whole mouth feels weird.
Exactly. That's the local anesthetic doing its thing. Usually temporary, though.
And what about, like, allergic reactions? I know people can be allergic to all sorts of things.
Oh, for sure. Allergic reactions are always a possibility, but they're pretty rare with local anesthetics. Always good to tell your doctor about any allergies you have, though, just in case.
Okay, good advice. So we've gone from completely shutting down consciousness with general anesthesia
Mm-hmm.
to like blocking pain signals in specific regions,
Mm-hmm.
and now even numbing tiny little areas with local
The
anesthetics.
whole spectrum of pain control.
It's wild to think about how much control we have over pain and sensation.
It really is. A testament to how complex, but also how kind of hackable our bodies are.
Yeah, I like that. So we've covered a lot today, from general to regional to local. What are some of the key things you'd like our listener to walk away with?
Well, I think the big thing is, all the stuff we've talked about, it really shows how powerful anesthesia is, right? I mean, it makes so many medical interventions possible.
Like, imagine trying to have surgery while you're awake and feeling everything.
Oh, I don't even want to think about it.
Yeah,
Anesthesia has truly changed the game.
totally. But it's also not without its risks, like you've been saying.
Right. It's not something to be taken lightly, for sure. It's complex and needs to be managed carefully by people who really know what they're doing.
So these anesthesiologists, they've got a big responsibility.
Huge responsibility.
Right.
But thankfully, the benefits usually outweigh the risks,
Right?
right?
Yeah, for sure. It's just good to be aware of everything.
And the cool thing is we're always learning more, always improving techniques, making it safer and more effective.
That's good to hear. I know I feel a lot more informed now after this deep dive. Like, I get it now, what it really means to be put under.
Right. It's not just falling asleep.
Yeah, it's like a whole orchestrated process, all these medications and techniques, and they're watching you super closely the whole time.
Exactly. And it's a team effort, too.
Oh, yeah, like it's not just the anesthesiologist.
Nope. There's nurses, surgeons, everyone working together to make sure everything goes smoothly.
It's a good reminder that even when we're like out of it, there's a whole team of people taking care of us.
Absolutely. So next time you're having a procedure, just remember all the expertise that's going into keeping you safe and comfortable.
Well said. This has been a really eye-opening deep dive into the world of anesthesia.
Yeah, definitely not your average nap time story.
Uh-huh, right. But seriously, I think our listeners are going to get a lot out of this, really understand how it all works.
Yeah, I hope so. It's a fascinating field, even if it's kind of behind the scenes most of the time.
And thanks again for walking us through it.
Anytime, always happy to geek out about anesthesia.
And to our listeners, thanks for joining us on this deep dive. We'll catch you next time. Keep those questions coming.